Okay, deal. Okay, ladies and gentlemen, we have got these teams in place here. We have the judges on top here. Just to update all, most of you know the game in and out. 4 teams, each has got 16 plus 2, 18 minutes. Okay, each player gets 4 minutes to talk. We give 2 minutes extra for the time in between changes. There are also going to be trophies for them. So you'll have 3 trophies basically. One is going to be for the best entertainer, who's making you laugh or whatever you like. The second is going to be on the best video, which gives you something to tell you, okay, I learned something here. And the third is going to be best team. Judges, all of you will make individual decisions. Okay? Nati, Jeevan Titiyal, Chitra, all of you, Piyush, I hope you have not been bought by anybody.
Not yet, sir.
Sure?
Absolutely.
Hey, Maharashtra ke ho?
Maharashtra ka,
Has
sir.
Lahane Saab given you something?
Not yet, sir.
Lahane Saab ne kuch nahi diya. Okay, so can we have the OPL introduction video, please? AV team. Audio, please, with video. Can I have the audio? Audio लगा ले यार.
दो नंबर देखो पहले सर
एक मिनट एक भाषा एक
पहले सर का
Can I have the introduction video, please? Can you play it from there? Audio, please.
Sir, player the demanding T-shirt.
T-shirt is with Namrata. Oh, bhai. Please from the beginning, please.
जीने के है 4 दिन बाकी जीने के है 4 दिन बाकी है बेकार दिन जीने के है 4 दिन बाकी है बेकार दिन जाए 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 एक बार जो चाहे जवान फिर ना आए जवानी फिर ना आए जीने के है 4 दिन बाकी है बेकार दिन जाए 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 एक बार जो चाहे जवान फिर ना आए जवानी फिर ना आए ऐसे न छोड़ो तेरा रास्ता जीने के है 4 दिन बाकी है बेकार दिन जाए 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 एक बार जो चाहे जवान फिर ना आए जवानी फिर ना आए
Well, ladies and gentlemen, let's hear it for the entire team. I'd like to also thank Santosh and Namrata for holding such a fantastic AIOS conference and their entire team in AIOS. Now, Mohan, are you ready with your team? 1 minute you are given, sir. 60 seconds starts now. Okay? And Mr. President, few comments from you, sir.
OPL has been the real thriller for all of us for last so many years, and it has really attracted audience not only for this country, entire world. I would like to thank Dr. Amar for getting this into the our society, and it's not only fun; it has a lot of educational material also, and we all realize this is what we require in science also. People have to learn, people have to enjoy, and today's teams are such. They make us laugh also. They make us learn something also. And I know that they have to give some bribe to all the judges also. Without that, they can't win. And in the past, there have been so many, such organizations. We have been judges for so many times, not got a single penny. The teams which are there, please be careful.
So captains, please be careful, all of you. Namrata. Oh, Namrata ji, please, President is saying something. He's saying he's not got any money from you. Okay, Mohan, you're ready of team?
Wait.
4 of you. When you're fully ready, let me know.
Is the mic on, please. Mic on, audio full.
Chitra,
Audio full.
few comments from you, Chitra. You're standing for this lovely post also. What is this? You're flooded with all gold jewelry. I'm seeing only gold jewelry on your rings. How many I can count? 1, 2, 3. Huh? Srini. Srini is one of the best retinal surgeons that you saw in India right now. And he's a fantastic human being and a great surgeon. Yes, Srini.
Sir, in the last OPL also I told, since most of these contestants are not paying us anything, I didn't ask much. So I think just 10% of shares from Agarwal Eye Care is more than enough for us. It will satisfy most of the people sitting here. We don't want anything else from that, sir.
I thought you were on my side, yaar. Huh? Mohan, ready?
Ready.
Okay, ladies and gentlemen, let's start. OPL starts now. Mohan, who has won, I don't know how many trophies.
Dandanaka, naka, 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 dandanaka, naka. Dandanaka, naka, 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 dandanaka, naka. எங்க தல டியாரே சண்டிமண்டுல தார்மாரே மைதிலி காதிலி இன்னாரு அவர் உண்மையா லவ் பண்ண சொன்னாரு மச்சான் அங்க தாண்டா தல நின்னாரே டண்டனகா நகா 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 டண்டனகா நகா டண்டனகா நகா 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 டண்டனகா நகா.
Friends, we are the crazy challengers. We are going to come up with some crazy videos you wouldn't have seen in your life. Come on, okay? And after this, lunch is being served outside. You can all adjourn for lunch, okay? Tighten your seatbelts, sit back, relax and enjoy. Thank you very much for my 91st OPL victory. Thank you, sir, Titial sir. And you can see here, I'm going to talk some science as well. What is that? That is a retina detachment. This is the Desmet's detachment, okay? Don't think that only Namrata can talk science. I can also talk science, okay? You can see here, this is an optic detachment. What is this optic detachment? When I'm putting this lens, this is a preloaded lens, the optic is gone, okay? My PG was asking me what type of lens. I said it's a new Pinot lens through which the patient can see very well, okay? Give a big round of applause for this very new innovation. Yeah, come on, this is another patient, Krista lens. I used to use a lot of Krista lens. Only the Krista came. Come on, these are the oops movements in ophthalmology. Only the Krista came. Where is the lens? The lens was in the injector. You can see that the haptic was in the injector, the lens, and about 10 people were watching the TV, and the patient came all the way from Coimbatore because Ramurthy referred the patient to me. You can see this is a patient again, you can see haptic detachment. What is haptic? This is a new lens, okay? The first time these guys came and told me, sir, this is the first apparent surface modified lens, sir, and it's got a beautiful optic, sir. Only the optic was there. Where was the optic? The optic came, the haptic came later. You can see that optic is in. This is another patient, trifocal lens. Again, very tight injector. You can see trifocal lens. And they were very, very sure this is a trifocal because there are 3 zones. You can see here 3 zones. Zone 1 for distance, and zone 2 for intermediate, and zone 3 for near. Okay, you can see that trifocal lens, beautifully cut, very nicely done. Again, you can see this patient aniridia lens. You have to be very, very careful with this aniridia lens. You can see I'm trying to do a glued IOL. I'm not told, do not do glued IOL. Come on, don't do anything else. Only do glued IOL you have to do. But the haptic got cut. Fortunately, I had another aniridia lens. You can see one of my phaco fellows was asking for some tips in phaco. Then I gave it to him. Okay, you can see the tips in phaco. You can see this is a second instrument. Okay, the second instrument, only thing is this instrument is not used for a long time. What happened? The second instrument got detached, okay, and got cut there. I never used this bimanual IA. Suddenly, one patient had some problem, then bimanual IA. And the bimanual IA was in the cupboard, and they took it out. it got stuck there as well. Okay, this is a bimanual IA detachment also. You can see the sleeve, and phaco, Amar started this sleeveless phaco, and this is the sleeveless phaco, and this is there, and sleeve went inside, and again the sleeve came outside as well. Diamond knife, okay? Diamond knife, very important. I said diamond knife, I'm using diamond knife. I tell all my patients, the diamond knife got detached, okay? But next day, I found this diamond knife was in Sujata's ear, okay? Then the diamond knife became diamond wife, okay? Again, you can see here MST forceps, which is very, very important. See, this is, okay, again, anaridia lens. See, MST forceps got detached now. Okay, see, this is MST forceps. Then I had to remove this because it became intraocular deformity. First in the life, first in the world, world's first, wherein my chopper, which is called Mohan Rajan chopper, notice very carefully, the chopper got detached there. And not only it got detached, it got also emulsified. You can see that, emulsified. Chopper detached and emulsified also. You can see the plunger detachment. You can see here silicon plunger. You can see the preloaded lens finishing. Along with the lens, the plunger also came. This is called the blue whale. Okay, you can see the blue whale. Haptic attachment. You can see the haptic gets attached to the trailing, the thing, haptic gets attached. Then what you do is, you take a simple, what do you do? Simple 11 blade and open up the cartridge. That is called the episiotomy. I named it as the ocular episiotomy. Okay, ocular episiotomy. You can see here ocular episiotomy I'm doing, and then after that it detaches again. This thing. Suddenly I found the silicone handle falling on the from the microscope, falling on the eye. The silicone handle from the microscope got detached. You can see this is the DSEC. Okay, Amar used to tell, do only this thing. Do only this thing. You can see only this thing. You can see as when the DSEC got detached as well. You can see here all fall down. All fall down means everything got this thing. In a live surgery, this happened. You can see here my assistant puts heavy monocular weight viscoelastic on the cornea. The nucleus goes inside. The assistant falls. The surgeon also falls. Give a big round for this, you know. Despite that, we did a vitrectomy and removed the nucleus. Thank you very much, ladies and gentlemen. Over to Prashant Baunkule, the chairman ARC.
Thank you, sir. So do all complex, can I have, yeah. Do all complex problems need complex solutions? Of course not. And this is what you need to learn from the crazy challenges. 13 years old male, primary wound repair done elsewhere, poor vision, BCVA 160, corneal scar, subluxated traumatic cataract, iris tissue loss, 4 clock hours, fundus hazy view, B-scan. And look at the cylindrical requirement, requiring almost 6 diopter of cylinder in historic lens. And it went to my friend from RP Center, Dr. Rajesh Sina, and naturally he had to advise him customize toric IOL with iris segment. Well, do we need that? My patient was not that rich enough to afford it. And so what we thought, do always complex.
That the relative motions are constrained. And
So
by which means
complex things,
and motion may be transmitted
complex
and modified as a
definitions,
screw-knit
no,
snap.
we have simple solutions. So what we did, so here we go, we do side ports, create side ports, we say, create viscosyneculalysis, rexis being completed with the help of a needle, and once the rexis is done, the lens was put, we decided that if we go back to the basics, bring down the size of the pupil to the pinhole size 1 or 2 millimeter, you can avert the need of toric IOLs, and that is what we did, and we wanted to improve the quality of vision. So the crazy challengers do not necessarily just put a lens, they wanted to give all better quality of vision, and that is what we do. We do multiple pinhole pupilloplasty, and here I'm trying to reduce the size of the pinhole, pupil to the pinhole size, and I bring it down. Then I refashion with the help of a vitreous cutter the pupil so that the Purkinje images are centered, and this is the end result. And you can see the patient required just 2 diopter of cylinder without the need of toric IOL. Case number 2, another 31 years old guy, firecracker injury, poor vision, 2/60. Look at a large corneal scar, traumatic cataract with a iris tissue loss of 5 clock hours. Now it goes to Dr. Luthra, Dehradun, another man with multiple hooks and rings. So we decide what should we do. Here he needed 7 diopters of cylinder, Again advised by Dr. Luthra, customized toric IOL with iris segment. We are not that fashionable. We go back to the basics. So that
Instruments
was
that
my
record,
step.
analyze, summarize,
Always
organize,
customized toric
explain
IOLs.
information that are
I need to do something simple. So again, went back to the basics. We did a phaco, we put a lens, and after that we decided to construct a pupil, iris pupillary diaphragm. There was no iris tissue loss from 1 o'clock to 5 o'clock. So approximated the iris, whatever was available, created a pupil. Once we create a pupil, we decided to reduce the size so that we have a pinhole effect of this particular patient. And with the help of a pinhole, we can bring it down. So multiple fourth row knot pupilloplasty is being done. And once we do a pinhole pupilloplasty, and then refashion the pupil, bring it into the center of the optical axis with the help of a vitreous cutter, and this was the end result. But you can see a month later, the pupil got dragged. So was that a defeat? No, of course not. We are crazy challengers. We decided to fight. We further went ahead with a second procedure a month later with a pinhole pupilloplasty, refashioning the pupil along, again with the help of a vitreous cutter. You can see that I have created further. Now the Purkinje images fall in the center, and we could achieve the target refraction, and this is the target refraction in a patient who was supposed to destined to require a toric IOL almost 7 diopter cylinder. So friends, not always.
A machine is anything that reduces human effort, sir.
So life can be as simple as that. You do not need much fashionable customized toric IOLs and anything. You can compensate for it corneal scars, astigmatism with the help of a simple pinhole pupilloplasty, which costs you less than 1,000 rupees. Thank you.
Over to the king of Bihar, Satyajit Sinha.
We are the crazy challengers, and I'm from Bihar. And when you are from Bihar, you expect some cataracts like this to be seen. I was not seeing a point of entry, so I wasn't very sure of what is behind. I went ahead and I was doing this cataract surgery in a routine manner. I did not know what was actually behind. It just looked like a synechia over there. And we were going ahead with the regular cataract. And now I have removed that adhesion gently. I am removing the debris over there. And then now you will see what I was not expecting. Below the adhesion was this foreign body was there. Now, because I could not see a point of entry, I hadn't done an X-ray also. So I had missed seeing this, which is some takeaway message from this presentation. And being from Bihar, I should have suspected because we have a lot of bullet injuries and all those things happening over there. So that was the first video which I wanted to show. The next video which I want to show is this is a uveitic cataract. No matter how much you dilate, it won't dilate. In these kind of cases, you have to remove the synechia which is there. When you remove the synechia, sometimes you will face some bleeding also over there, hyphema. The rings will not necessarily work in these cases, so you have to use iris hooks. So I'll little fast forward these cases. Even in these recurrent uveitic cases, the visualization is a little compromised because the corneal haze is also there. So you have to be very, very careful when you are doing these surgeries. Also, the additional problem is iris prolapse. So from time to time, you will see that I'm hydrating the cornea to prevent the iris prolapse. And now, gently and slowly, we go and rotate. Because this is a soft cataract, it makes things even more difficult. You can't just go directly and do the chop technique. Once you have finished that, then I'll move a little more faster. Even this, the cortex, remnant cortex is a little sticky in these cases, so you have to be very careful with limited visualization. And once you have done that, then you have to be very careful even in polishing because the posterior capsule is also fragile. Again, you will see me hydrating the wound because of this iris prolapse. Once you have done all that, then it becomes a regular thing, and you want to fold and put the intraocular lens properly so that you don't get a broken IOL going inside, so on and so forth. So once that is over, now this is another video in which I was doing a cataract surgery. I was very happy. I had finished the case. I loaded this myself in a hurry, last case. And once I put this in, you will see what actually happens. I'm being very careful. I put it very nicely, and then this is what happens. Half the haptic is not there. So once this happens, as Dr. Amar Agarwal sir has already taught all of us, first we have to park this to one side and then go ahead and put the other IUL first. So now you will see in this video, I load another IUL, and then so you can secure, because all the time that you are doing this surgery, the iris also goes on becoming smaller and smaller. Once you have parked it to one side, then you go ahead and put the second IUL first, secure your posterior capsule, and entire India and the entire world is grateful to Dr. Amar Agarwal for this procedure that he taught all of us. And then you go ahead and remove the IUL. You cut it into 4 pieces, and generally you do not need to expand the main incision that you have made. You can make a triangular wedge and just rotate it and take it out. So you can just bring it to the margin and then just pull it, rotate it, and take it out. Now, the last case which I want to show you is, this was a very challenging case, as is our team's name, Crazy Challengers. I was... one more. You will see that the capsule is so fibrotic that no matter how hard I tried, I could not open the anterior capsule, and I had a very, very tough time. Eventually, I used vanas and so many things and a cutter, but still it didn't work. And so much pressure is being put, so which is not the correct thing. So in the end, finally, I found the rhexis margin. We went ahead and then completed the rhexis margin, which was quite in the periphery. Thank you so much.
Thank you very much, Satyajit Sinha. And over to the wizard from Tamil Nadu, Prasanna Venkatesh Ramesh.
Thank you for the opportunity, sir. So next, can I have my video? A video of a person who wanted to be a filmmaker or a film editor getting into ophthalmology. Let's play the video, please. Yeah, this is the story of a young boy who wanted to make a movie, Timeless, who did make it during his undergraduation period, making the glaucoma out. Yeah, the photoreceptive glaucoma. You can see that yeah, there is a small laser spot given for a YAG PA, one of the tough videos to document, where you can see that the YAG PA spot photo disruption being documented, photo disruptive glaucoma. Cut 1 by the editor. Cut 2, let's see titratable glaucoma. Cornea 1, cornea 2, suture. Cornea 2 and sclera 1. So these are all highly edited videos. Sclera 2 and sclera 3. So this is how you go for a releasable suture. And then after putting 4 knots, 1, 2, 3, 4, titratable glaucoma. How do you titrate the glaucoma? It's a releasable suture. Editor's cut 2. What do you do in post-op? Just release it. Again, fast forwarding and going back the video. A simple ocular massage and the bleb gets formed. Cut 3. Serous coronal detachment with overfiltering bleb. Seedles negative. What do? The bleb is actually going for overfiltration. Compression suture, putting an X on either side of the bleb and creating a barrier. It can be done in an X-shaped manner, or it can be done in a parallel manner. Serous CD, bleb is seedle negative but overfiltering. Compression suture, and the patient will do excellently well. Don't need to intervene. And this is Palmberg suture, parallel to each other. Cut 4, the transscleral glaucoma. Ab Miyake view, where you can see the blasting of CPC diode. Same procedure. Cut 5, CPC endocycloplasty, going in, seeing the ciliary body, cyclomodulating but not fully destroying. Endoscopic glaucoma. Cut 5. Before and after CPC, you can see the angle opens up. Cut 6, malignant glaucoma, iridozonulohyaloidovitrectomy. Doing a PI anteriorly, putting a port, going in, see, again rewinding the video, how the aqueous comes out because of the misdirection into the vitreous, doing a hyaloidotomy, coming up through the PA area, doing a zonulectomy. Cut 6, IZHV. Another procedure, same. When you come out, sometimes you may catch the iris, and that's a sign the chamber will deepen. Malignant glaucoma. cut 6. Let's see cut 7. Avoid taking flaps. My mentor always say avoid taking the flap in the filter when there is a perforator. That we always do it and learn it. When there is 2 dots, don't take the flap there. If you do it, see the video, rewinding it back, it just causes a nightmare. Cut 8. In this case, what's happening? Temporal view, the eye is moving. In superiorly intraoperative nystagmus, you can see, despite a block, the base was shaking. Cut 9, one of the pseudo valve where RD doesn't have a valve. A 50 prolin suture, inserting it into the valve and then following the similar procedure. Editors cut 9, a pseudo valve, and then completing the whole procedure. Let's go for cut 10. If you don't have a triangular flap, a quadrilateral, always make the sutures perpendicularly, otherwise it's going to leak. Last but not the least, peripheral iridectomy. When there is bleeding like this, never, never, never wash it. Just using the flap, cut 11, flap for tamponade. And last, trabeculotomy with trabeculectomy, the rehabilitative glaucoma. The baby, a Sturge-Weber case, operated on 15th day, and the baby is doing excellently well. A tiny hero's triumph to glory. So with that, that's my journey. Didn't become a filmmaker, but became an ophthalmologist and also into editing. Thank you.
Thank you, Prasanna.
This is for entertainment.
Friends,
once again.
that was a master class on glaucoma. Thank you very much. Crazy Challenges, a combination of science, fun, and fantastic costumes as well. Thank you very much. Amar, thanks a lot.
Thank you very much, Mohan. Maipal, please come on stage there for your team. In the meantime, Lane Saab, how confused have you become after all this?
Basically, he has time, 10 minutes more. So any computation, if the time is not kept, he should not be inside. He may be, yes, 10 minutes. 10 minutes. So 10 minutes. Secondly, what he shows, the hole in the lens. If a hole in the lens is there, where the lens has gone? He has made hole before and then put for OPL. It is not hole in it. So it is like that. Because he always, and he whatever he has broken outside and then shown. It is like that. Nothing happens. He has done so many things, but nothing happens. Okay.
Mohan, Professor Lane is saying you're making videos specially for OPL.
Absolutely nonsense. Sir, what is this? Hey, what is this? What is this?
Wait, listen, for center for site, 500 rupee note is very less. Okay? But it's up. For center for site, Srini, don't take 500 rupees.
And that too Purana notes, old notes.
Well, ladies and gentlemen, let's hear it from Mohan and his team. Okay, and now we have the next team with us, which is Mahipal and his team. And I always say, sing is king, ladies and gentlemen. Let's hear it.
कि तेरे संग यारा अख लड़ने लगी अख लड़ लड़ के आगे बढ़ने लगी एक तेरे संग यारा अख लड़ने लगी अख लड़ लड़ के आगे बढ़ने लगी ओ तेरे दिल के इशारे ये तो पढ़ने लगी अख लड़ लड़ के आगे बढ़ने लगी ओ मुंडा जिद पे अड़ा ओ तेरे पीछे पड़ा
Purchased 10 years ago, 12, 14 years ago, didn't see the posterior subcapsular or a posterior polar cataract. By the time half the nucleus was taken away, we had a big rent. So what do? Trying to mobilize, hadn't done a good hydrodissection, trying to mobilize the nucleus, made a incision, stab incision at 6 o'clock, and trying to get out the nucleus. It's already pre-chopped, so getting 2 hemisections is not a problem. Got 2 hemisections, bring them out over the iris and go in with a Technis 3-piece lens. Important thing is, don't put it below the iris, but the haptic should be over the iris, and then you can go ahead, because it's a pre-chopped nucleus, you can go ahead with gentle aspiration and minimal phaco. Doing a vitrectomy, the entire thing is taken out. Because the capsular axis is rock solid, we go ahead, dial the 3-piece lens onto the top of the capsule. Now this is another case. You can see here trying to do a phacoemulsification. You can see it's a Morgagninian cataract, and we were not able to get a good capsular axis because it was totally tilted, and there was a particular area of weakness. So as we go ahead with this dense cataract, you can see again a big posterior capsular rent that has happened. So go ahead, again put the haptic on top of the iris, and you work on this scaffold and you take away the nucleus. And then what we have to actually do is that there was a, you have to, because there is an absence of posterior capsule, so we want, and the interior was also not good, so we want to do a fixation, and also we removed the small piece of nucleus that had gone in, and do with a glued IOL. Finally, case 3, small pupil, left aphakic, and was sent to us, I think, by Mohan, and and then you can see what we are going to do is to try and have a good visualization. So what we are doing in this particular case is to use a Malugan ring. So a Malugan ring, apologies to Suven, but Russia gives us oil, so we have to use the Malugan ring. And you can see that this was the whole complex that was that had fallen back. So we are removing the whole complex now. Now here is where the twist comes. We are doing the scleral fixation, and just watch this haptic. What is being done, or what is the fault, is that the haptic has been pulled out in between the Malugan ring. And this is one step, one mistake, and you can see that we are trying to pull it out and the Malugan ring has fallen down. So simple as we can do anything, we divide and we conquer. So we just cut the Malugan ring, and that is all that is required, and that is paradise regained, and we are able to get the lens in position and do the scleral fixation. So 3 difficult cases that I have showed you, wherein end result was fantastic, and we were able to get good results. Thank you very much. Thank you.
Great video, Doctor.
Over to you, Dr. Arun, the man from Ajmer, Rajasthan, who is hosting this conference for us.
Thank you, Dr. Mahipal. So this patient presented to us with a posterior polar cataract and a pre-existing posterior capsular rent. And I was so excited to do this because I was hyper excited. But Shifu told me to calm down, to have an inner peace and manage this case very calmly. So this is how I went ahead. First, I put in my trocar and cannula through the pars plana, stained my capsule with trypan glue, performed 5 to 5.5 millimeter capsular rexes. Since it was a posterior polar cataract with pre-existing rent, so hydrodissection was a big no-no. A gentle hydrodelineation was done so that I can separate this nucleus. Even though we are divide and conquer, but here I prefer to go and do a direct chop. This was a grade 4 nucleus, a gentle direct chop, dividing the nucleus into 2 pieces. And then first of all, I attack the nucleus at 6 o'clock position, breaking down into smaller pieces and emulsifying it without rotating the nucleus up till this stage. So once the whole of the nucleus from the 6 o'clock position was emulsified, then the nucleus was slightly rotated, and the rest of the nucleus was emulsified in a slow motion with slow motion parameters, taking care not to lose the grip on the nucleus, because if you lose the grip on the nucleus, this nucleus will fall down into the vitreous cavity. So slowly and slowly, the whole of the nucleus is emulsified, brought down, keeping in mind to keep my chamber stable. Before I withdraw my phaco-emulsification probe, I maintain the chamber with a viscoelastic, and once all of my nucleus I have emulsified and taken out of the eye, next is to go in and do some vitrectomy. So I go through the pars plana to the cannula which I had already put in, remove all the vitreous which is present in the capsular area, in the bag area, and in the pupil. So once the all the vitreous is out, cortical removal becomes a cakewalk. The cortex come out very smoothly. The very fact that the cortex is coming towards the aspirating port denotes that there is no vitreous present in the anterior chamber or anywhere close there. So once the whole of the cortex is cleaned up, it's a cakewalk now, because there's no vitreous, and I have a good anterior capsulorhexis. Once the cortex is out, a good viscoelastic goes in, a 3-piece IOL goes in. First the IOL sits on the iris and then it is dialed into the sulcus above the anterior capsulorhexis. The IOL is inside now under the iris and above the anterior capsule. The whole of the viscoelastic is removed. Anterior vitrectomy is done to remove the remaining part of the vitreous. Triamcinolone is injected to check if there is any vitreous stent left in the anterior chamber, and before I close, I capture the optic in the anterior capsulorhexis. Here you can see that I have captured the optics, and once the optics is captured, you close your hydrate your wounds, and then you remove your cannula. And now this is how we are going to destroy all our opponents. Skadoosh.
Thank you very much, Arun. And now we have Priya Kiara Advani with us, who is the Ksada Khara Khara, and she is going to show her fantastic videos, and that is Udar Wala Lagao. And that's, we are sure to win from Namoland. Go on to Dr. Priya. Yeah.
Good afternoon, ladies and gentlemen. I'm going to show you something much more about iris repair. So this is one of the case, it was one of the surgeons had referred this, and you can see there's a big chunk of iris tissue that is missing in almost one of the quadrant, and the remaining iris tissue around the pupil is also atrophic. So handling these cases is actually very challenging, because you know the sutures, they do not actually pass very well through this atrophic iris tissue. So what I've actually decided is that I introduced the trocar anterior chamber maintainer, and now this is the double arm 9O polypropylene suture, and you know I'm trying to cover up the peripheral iris defect as much as possible, because this patient had a lot of glare in the post-operative period. So I'm trying to pass on the sutures, if you're noticing, I'm trying to pass it on through the healthy iris tissue, because that is where it will actually hold it. Now in this surgery, I'm trying to do this, I try to repose it on one side, and now I'm trying to cover up the iris tissue, the iris defect on the other side too. Having done this much, what I actually realized after doing this, that almost the entire area of the defect has been transposition. Actually, now it's simple to create a pupil, because what I will be doing now will be like passing on the suture needles through the healthy iris tissue, and now the pupil reconstruction, the central pupil reconstruction can be done very well. So what actually I'm doing here is the single pass 4-throw pupilloplasty procedure. This is a single arm suture that passes through the proximal and the distal defect, and then you just take up 4 throws and you pull up the suture ends and you close up the defect. Now we also have to close the peripheral defect in this case, because we have to cover up the entire optic of the intraocular lens. Otherwise, the edges of the IOL can give a lot of glare to this patient. So this patient actually behaved very well in the post-operative period, and these cases actually are very difficult because, it may happen that, wherever you are passing on the suture, the iris tissue might keep on giving way, and a little bit of bleeding or hyphema you do see in these cases because they are already insulted eyes. So that was the post-op image of the case. And this is another case. The surgeon had done a surgery, and then it was a mess. There was a history of trauma, and then everything had come out. So I just had to explant that multifocal intraocular lens out there, and luckily the bag was intact. So I've just taken up a 3-piece intraocular lens, and I'm trying to put it into the capsular bag. So having done that looks quite good, but I was not very sure at this moment that whether I will be able to do the iris repair. So like it almost took me 15-20 minutes to get this iris inside the eye, try to find out the anterior and the posterior side, and once having diagnosed that, I just placed up the iris hooks so that it does not again go back into the incision, and then it becomes actually easier to do the repair. So now again, this is the non-appositional iris repair, a double arm suture being taken up. The scleral groove we always try to make. You can even make a Hoffman's pocket if you actually want it. But here, it's easier to do it with a groove because you pass your sutures through the groove, and then you can bury those knots there. So like you go through, you keep on doing the non-appositional iris repair as much as you need, and depending on this. For example, in this case, almost like it was three-quadrant defect which was present. So had to do quite a bit, and it took quite a bit of long time. Always use viscoelastic to flatten up the iris tissue because the iris tissue tends to crumble, and then if you try to do a pupil repair, you can get an eccentric pupil, correctopia, on the table itself. So having done this, what I actually noticed is that, okay, I could do an iridodialysis, but like you also need to create a functional pupil for this patient. What I have actually noticed is with the iris repair, even if you create a functional pupil for these patients, they actually behave very well in the post-operative period. They're quite happy because quite a bit of things are being taken control of. But like this patient had that IOL rubbing onto the corneal endothelium, so now this patient is actually scheduled for an endothelial keratoplasty. Otherwise, this patient behaved very well in the post-operative period. Thank you so much.
Thank you very much, Priya, for the excellent videos. And we come to the President AIOS for presenting his case. Over to Partha.
President AIOS. Yes. So, let me tell you the background of these stories. Vice President Mohan Rajan invited me to Rajan Eye Care. He said, President, you have to operate in my OT. I said, yes, of course, why not? But beware, Nabnata Sharma, you have operated in Rajan Eye Care. Gaurav Luthra, you have operated. Lahane sir, you also have operated. There are devils there. And those devils are what they do to the host and to the president of AIOS. So I did a smile. I flew the patient of smile to Rajan Eye Care. And then 3 months later, the patient says, I spent a fortune and my power has come back. So I said, don't worry. We have a solution. The patient said, don't take me back to Rajan Eye Care. I said, okay, we'll do the circle software at Trinetralaya. We will do it, sir. But I was really scared. The circle software, will it access that same lenticular plane? Yes, it does. The smile, if it has to be retreated, it has to be retreated by circle software, where? Not at Rajan Eye Care, at Trinetralaya. So we did this. We put in the flap back again, and the next day, patient was 6'6", N6. Crystal clear cornea. I saved myself from the devils of Rajan Eye Care. The next one, he says, thank you, doctor, for not taking me back to Rajan Eye Care. But then again, this patient, so he said, Rajan said that I'll provide you the ICL. I will provide you the ICL. And I'm doing it at Rajan Eye Care. Oh my God, I've never had such a situation. ICL, अरे क्या हो रहा है? ये stuck कैसे हो गया? पूरा plunger भीतर चला. I said, Mohan, do something, yaar. अरे It's gone all inside. Hurry, now the IC. Oh God. He says episiotomy. I never did it in my obstetrics. Oh God. Now, that was me. And that was the mop Mohan Rajan has for everyone. But once this ICL is severed, it is a tough situation. Because it has reduced itself in size, the iris can keep popping. You have to be extra gentle. And I try and grasp it with the ICL forceps. I catch a nick, it will not come. And just remember, there's just that 3 millimeters inside. So what I do, I put in a little bit of viscoelastic and position so that the haptic that was not severed is actually near the entry wound. Ah, I've got it. So Mohan says, you've got it, boss. Now you just take it out. Take it out. Take it out. So I said, Mohan, wait. Mohan, wait. So I take it out. I take it out. Oh, God. Only the haptic comes out. Mohan is always there. Mohan and his sisters are always there. And he has a physician too. But my heart, oh God. And he says, no worries, go back. We are there for you. The physician is there. He'll pump in adrenaline. And then finally I place the ICL over, and with viscoelastic cover, the iris is still popping out. Still popping out. But I think I have a grasp now. And I take out the ICL. Never again, I have vowed to myself, will I go to Rajan Eye Care to do a surgery. I tell you, I warn you, OPL guys, warn you, never do that. Never do it.
So Mohan, lunch is served now. All of you can go. Thank you very much. Thank you from
Thank you, Mahipal. Thank you very much. But Mohan, how confused are you after all these surgeries?
You know, recently I released my book called Rajan Effect. You know that, no? Biography. That the Rajan Effect is there on Partha. At least 15 times you would have mentioned Rajan Eye Care. Henceforth, I am going to ask Partha Biswas only to do all the lectures because it is a publicity for Rajan Eye Care for me. Free publicity.
So Mohan is not able to do cases now, so he is trying to sell his book and distributing free of cost. So all of you can take it and give it to the Raddiwala to make...
No. This guy is... No, this...
You know Chota Rajan?
I know Chota Rajan.
Where is he?
No, he is here only. Bombay. I am Chota Rajan. Anyway, I am Bada Rajan. Wait. This guy, Mahipal Sachdev, Center for Sight, I don't know what they are doing, man. I don't know what they are doing. They are having the lens there and full of vitreous, and then he is putting the lens there, another IOL, and then without doing any vitrectomy, you are doing the IOL scaffold. What nonsense is this? And you're supposed to have, how many centers you are having now? I will disqualify you first.
See, I have to come to Chennai, right? He's come to Delhi. I have to come to Chennai, so I'll join you.
I'm caught in this family way.
Prashant, what is he saying? Confused? Are you still confused?
Totally confused, sir. Totally.
Well, ladies and gentlemen, let's hear it for Sardar. Sing is king, ladies and gentlemen. Well, the next team we have is Professor Lahane and his team. Lahane, all yours.
Thank you very much, Amar. And now this is the mighty multifocal team. Myself, Dr. T.P. Lahane, and none other than Kunar sir. Can see the Dr. Kumar and Rohit. So we are presenting. You can see up till now you have seen the Mohan is taken over by the Partha like that. So now we will show you the fun, also the science, and this is our team, and I'm presenting the first video. इसको ये आवाज दिया है? Okay.
देखो गोंजाल्विस, इस दुनिया में दो तरह के प्यूपिल होते हैं, एक जो डायलेट हो जाते हैं और दूसरे जो डायलेट नहीं होते। डायलेट होने वाले प्यूपिल के लिए T+ और एट्रोपिन जैसी दवाएं बनी हैं, लेकिन जो प्यूपिल डायलेट नहीं होते उनके लिए अभी तक कोई दवा नहीं बनी है।
कौन है ये लोग? कहां से आते हैं?
So now this is the non-dilated pupil. जो दवा नहीं बनी है वो हुक से बनी है, and then I'm doing the rhexis you have seen in the non-dilated pupil, and the trench always instead of chop, trench is always better. You have made 2 pieces, and once you have made 2 pieces, then your job is finished. So see, this is you can see I'm making the pieces and removing in the small pupil. So that is done and lens is implanted.
देखो गोंजाल्विस, दुनिया में 2 तरह के कैटरेक्ट होते हैं, एक सीधा कैटरेक्ट और दूसरा सबलक्सेटेड कैटरेक्ट। सीधे कैटरेक्ट के लिए तो फेको मशीन बनी है, लेकिन सबलक्सेटेड कैटरेक्ट के लिए अभी तक कोई दवा बनी नहीं है। कंट्रोल कंट्रोल।
So now this is the subluxated cataract, and I am using the iris hook for this.
चीटिंग करता है तू, चीटिंग करता है तू।
So these iris hooks are used, as you can say the capsular hooks are not used, as it was not there, and then this subluxated cataract with the support of CTR and hook, I am operating it. So both are used so that supports more and power is reduced, and you can see the hook, what I am doing is just blunt chopper I am using, so that will not trouble the PC. So you can see though it is a subluxated.
दुनिया में 2 तरह की कॉर्निया होती हैं, एक क्लियर कॉर्निया और दूसरी सफेद कॉर्निया। क्लियर कॉर्निया तो अच्छी रहती है, लेकिन सफेद कॉर्निया के लिए अभी तक कोई दवा बनी नहीं है।
So this is the corneal opacity, and I am doing the SICS, and nothing is seen here.
Turn off the light.
टाइगर का हुक्म।
So you can see this with the chandelier. Nothing is seen, but because of the chandelier, courtesy to Saili, my daughter. The rhexis is done with the chandelier, and I am removing the lens in the anterior chamber. You can see this is the cornea, but small place is this cornea is transparent, and you can see I am removing the lens also with the chandelier. The lens is removed by the chandelier, and the aspiration, and the lens is implanted by the chandelier here.
रिश्ते में तो हम तुम्हारे बाप होते हैं, नाम है शहंशाह।
Thank you very much. So now the Rohit Om Prakash. Yes, Rohit.
Thanks, Dr. Lahane sir. Let's see how we can manage posterior capsule ruptures.
Posterior capsule tear is one of the most dreaded events in cataract surgery, often associated with nucleus drop and compromised visual outcomes. With better understanding of anterior hyaloid face integrity, posterior capsule tears are managed differently. The flutter sign demonstrates this in graphical animation. A PCT is present. Sharp and gently fluttering tear edges indicate an intact AHF. Here, the AHF is ruptured with vitreous prolapse. The tear edges lose fluttering and appear scalloped and fixed. Flutter sign is now a published clinical indicator providing a real-time marker of AHF integrity. In this video, PCP is present. Tear edges are sharp and fluttering, indicating an intact AHF. During unmindful withdrawal of the phaco handpiece, vitreous prolapse occurs. This illustrates the importance of chamber stability and highlights that PCT and vitreous prolapse are two distinct events. Typically, PCT is followed by AHF rupture and vitreous prolapse. Low fluidics create a controlled, slow-motion phacoemulsification favoring AHF integrity. A stable chamber supported by calibrated incisions reduces fluctuation. Gentle mobilization of nuclear fragments without rotation within the bag limits stress transmission to the AHF. Low turbulence and AHF friendly environment makes the AHF an ally. Anterior chamber deepening, shallowing, and turbulence may predispose towards rupture. ASOCT reveals a pre-existing posterior capsular defect. In this video, low intraocular pressure nuclear emulsification is done with stable chamber settings and measured nuclear maneuvers. The flutter sign indicates an intact AHF and guides safe surgical progression. Chamber stability is maintained. Cortical aspiration is commenced. Real-time confirmation of intact AHF by flutter sign guides cortex removal using AHF-friendly parameters of low intraocular pressure and a stable chamber. Now, sharp and gently fluttering PCT edges highlight AHF integrity. Chamber stability is maintained. Under stable conditions, the tear edges are rounded off to facilitate in the bag IOL implantation. Toric IOL is implanted. The haptics are aligned in the required axis. Gently, haptics are flexed sequentially into the capsular bag. Triamcinolone confirms the absence of vitreous. An intact AHF is observed with half of the nucleus within the capsular bag. 20 millimeters of mercury pressure is maintained with low fluidic parameters. Small nuclear fragments hover and float within the anterior chamber. The intact AHF boundary functions as a protective shield, preventing posterior migration of the small fragments. The minimal pressure gradient between the two segments prevents posterior displacement, allowing the fragments to remain suspended in the anterior segment. One fragment is expressed effortlessly. The second fragment is gently guided out of the eye. Here, ruptured AHF shows PCT edges static and scalloped. There is a loss of posterior support. Subsequently, a nuclear descent occurs. Hence, with the PCT, use of low fluidics, flutter sign appreciation, AHF-friendly maneuvers, timely recognition of AHF rupture, and early vitrectomy helps improve outcomes.
Thank you very much.
Rohit, thank you. Thank you very much. You have seen the science, and now the Dian of Ophthalmology, Santosh Honawar, and I think he is the best plastic surgeon in the world, ophthalmic plastic surgeon in the world. So Santosh.
Thank you, sir. This is something beyond cataract. Let's see what ophthalmology does beyond cataract at all. Can I have the video?
Grand finals of the Orbital Premier League coming to you live from Jaipur. Today's high-stakes face-off between Orbital Titan versus Dermoid United. The pitch, the supratemporal orbit. Dermoid United has been occupying this orbit for years, but the Orbital Titan is known for one thing: clean extractions under pressure. Dermoid United, a seasoned orbital squatter, famous for one unpredictable move, rupture. But facing it today, calm hands, steady strategy, the Orbital Titan. Setting the field, reading the pitch, the surgeon begins with careful marking because in orbital surgery, precision is everything. And we are underway. Here comes the opening move. Beautifully executed incision right on the mark. Clean entry through the skin. Excellent, excellent control. Dermoid United hasn't moved yet, but the pressure is building. Layer by layer, the surgeon advances. Meticulous dissection, respecting the planes with excellent control. The capsule is beginning to come into view. Dermoid United looking slightly uncomfortable now, but still holding its ground. But this is where matches are won or lost, and experience really matters. Tight adhesions, very little room to maneuver, minimal room for error. One sudden rupture, and Dermoid United could turn the game around. With the capsule almost free, the surgeon is closing in. The entire stadium is holding its breath while the surgeon thinks aloud. ये डर्मॉइड लेफ्ट से रप्चर होगा, वहाँ से काफ़ी थिनिंग है, लेकिन प्रेशर तो राइट पे आ रहा है, राइट से होगा, नहीं लेफ्ट राइट, या खुदा ये तो सीधा बीच में से रप्चर होगा। सिस्टर मेरी तरफ देखो सिस्टर, लुक एट मी। Steady hands, controlled traction, the orbital titan holding his nerve beautifully. And there it is, capsule delivered completely intact. The orbital titans finish it off in style. Let's look at that again. Perfect dissection, controlled traction. Dermoid United completely outplayed. Hemostasis achieved, closure underway. Textbook finish from the orbital titan. And here is the defeated opponent, one intact orbital dermoid, a tiny dermatology department, years of illegal occupation, ended in a single surgical innings. And with that, the final whistle blows here in Jaipur. Final score in the Orbital Premier League. Orbital Titan 1, Dermoid United 0. Victory by capsule intact. And we go live now to Mumbai. Careful dissection, steady hands, perfect control, and that's another one out. Next stop, Chennai. Dermoid United settled comfortably here, but flawless execution, and Chennai joins the scorecard. Now we head east to Kolkata. The Titan circles, waits, and strikes with precision. Capsule preserved yet again, and it's out again. Coming to you from Delhi. By now, Dermoid United know exactly what's coming. Game, set, match. Different cities, different patients, but the same story every single time. Long live the glory of the Orbital Titan.
Thank you, Megha.
So friends,
Santosh, and now Kumar doctor. Yes, Kumar.
So friends, OPL is not only cataract, so you saw something which also has a capsule but not in a cataract. So now we're going to show you two very interesting cases, and watch this. Audio.
Dr. Bond, we have a situation and a few challenging cases, and we need you to come in immediately. Vacation's over, Dr. Bond. There are a couple of challenging cases, and I need you to step up.
Trouble never takes a vacation, Dr. M. What's the case?
It's a bad case with the IOL in the vitreous. Extracting it will be like disarming a bomb. One wrong move and the eye's lost. What's your plan?
Sounds like a typical Tuesday, Dr. M. Let's get to work.
Dislocated IOL in vitreous, no documentation, IOL design unknown.
Options: explant the IOL and glue another one, or a posterior iris clip. Flaps are made through 2 sideport incision, started the anterior vitrectomy. To our surprise, the lens came up, held with the micro-grasping forceps and brought into the AC. This is a non-foldable 6.5 mm optic IOL with dialing holes and a 10-degree angulation. Notice the orientation of the haptics. To correct the orientation of the IOL, we flip the IOL in the AC. This is a rigid optic with large J haptics which are extremely brittle. Since we have the right orientation, the same IOL can then be carefully externalized and the haptics can be glued in position.
Let the lens fall. When it crumbles, we will face it all. Flip, refit together and stand tall.
In conclusion, with 2 minimal port vitrectomy, it is possible to flip the same IOL and refit the same for brilliant visual outcome.
It's time to get serious, Bond. This is quite a case. One of our agents has an iris clip IOL in C2. It's a phakic IOL and now he has a cataract as well. What are you going to do about it?
I have a trick up my sleeve, Dr. M. Just wait and watch.
Enough with your quips, Bond. This is your last case and then you can go back to your vacation. Patient operated 30 years back. Non-foldable iris clip phakic IOL develops a cataract.
One option, explant the phakic IOL, take a suture and create another wound.
So some of you
A
might not have
completely
ever
new
seen
approach
this.
is to perform CCC under the phakic lens in place. So leave the lens in place, followed by hydrodissection and phacoemulsification in the bag, followed by bimanual IA under the iris clip IOL to remove the cortical matter, followed by replacing the IOL and suture in place to prevent astigmatism. This is followed by disengaging the iris clip IOL and replacing it by another IOL.
Under the clip, the phaco's done with precision. Iris good as new. Are you willing to try? Steady hands, balance remains. You know my name.
An innovative approach to cataract removal under phakic IOL, followed by IOL exchange and suturing to prevent astigmatism.
Congratulations, Dr. Bond. You've restored more than just vision today at His Majesty's Vision Services.
Turning complex cases into simple procedures, that's what I'm here for, Dr. M. Thank you.
Thank you. Thank you, everyone. And that you have seen the multifocal science, fun, and science. Thank you. Thank you very much.
Partha. Thank you very much, Professor Lahane. Now, Mohan, how confused are you with
No, totally. I think we should disqualify this team totally. Because absolute nonsense. And Santosh as planter every OPL. Santosh will have 20, 30 of his postgraduates and fellows. They'll all clap only for Santosh. See this? They'll all clap only for Santosh. What is this? No. Big hand also.
Just 4 of them, 4 frail girls taking over 400 people. How is that possible?
Partha, are you able to compete with that?
For once, I think Mohan is right. For once, I will say Mohan is right. Mohan.
Lahane Saab, what are your comments on this?
No, see, it is like that, they are jealous. They are jealous because he is famous, so they are jealous.
Thank you very much. Well, ladies and gentlemen, let's hear it for Lahane and his team, and let's have the final team, Dr. Namrata's team. Before she starts, remember, the voting is going to depend on you and the judges. So judges, get ready. Namrata, all yours.
So don't start the recording now because this is a housekeeping announcement. We are on our way to create world record. This is a request from the LOC. The largest sentence made from citrus fruits just outside this Mugdha hall. So when you go out until this 4 p.m., please put a fruit there so that AIOS creates history. Now coming to the introductory video.
जलवा दिखा देंगे हम
And now over to you, Dr. Anaka Harur, our opening batsman.
Thank you so much, ma'am. Can I have my video, please? Friends, last night I had a strange dream. I found myself in a silent winter forest, snow everywhere, trees standing tall and still, and I was riding through the woods. I stopped beneath a tree to rest. Suddenly, my horse grew uneasy, restless, alert, sensing something which I could not yet see. Then I saw it, a tiger emerging silently from the woods, its eyes fixed on me, moving closer step by step. Instinctively, my horse panicked, and there the tiger was too fast. It lunged straight towards me, and as I scrambled up the nearest tree, I tried to defend myself, firing at the tiger, but it leapt towards the trunk, trying to climb up after me. For a terrifying moment, I felt like escape was impossible, but then it stopped. It couldn't climb any higher, and finally perched safely above. I sighed a sigh of relief. I thought escaping the tiger in my dream was the biggest challenge of the day. But the next morning, a patient walked into my clinic for a second opinion. And trust me, the 4-diopter refractive surprise done elsewhere felt far more dangerous. So the patient was extremely unhappy, and I had to do an IOL exchange. So there I was. I filled in the chamber with viscoelastic, chondroitin sulfate and sodium hyaluronate to protect the corneal endothelium and the PC. And using an ultrasonic cutter, holding the IOL firmly in the left hand, it cut through it smoothly like butter. With a power at 40, vacuum and flow rate at 0. Holding the IOL firmly, you can see how each piece came out very smoothly without extending the incision. The corneal endothelium and the PC was also very safe. And the next IOL was put in, restoring the patient's vision. I felt victorious, like I'd escaped the tiger, but dreams have a strange way of continuing. Because the next moment, I was back on the tree in the middle of the forest, perched on the branch, gun ready, thinking that the tiger had walked away. And I began to believe that danger had passed. But suddenly, out of nowhere, there it was again. The tiger leapt towards me, its claws striking fiercely, and as it pounced, locked in a struggle, we were sliding down the tree trunk together, branches cracking under us, and at that moment I realized this battle was far from over. And friends, you will agree that some battles are fought in the jungle and some in the operating room, and this was my second challenging case. A central adherent leucoma, which was stuck to the iris, and inferior 1/3 was totally obscured. So the first strategy was to open up the adherent leucoma. So I cut it with microforceps, and the second move was to expand the pupil. So I put in a B-octa ring, and it immediately opened up the view beautifully. So even though the central opacity was there, look at how the expanded pupil dramatically improved the visualization, and the rest of the cataract surgery was safely performed. So sometimes in difficult cases, even a small strategic move can completely change the battlefield. Once the IOL was implanted, it was very easy, and then the B-octa was removed from the main incision. Friends, battles don't end so easily, do they? Because in my dream, the tiger was still circling the tree. After that fierce struggle, I had managed to climb back up to the tree once again. But I climbed down now, ran to retrieve my rifle, lying on the ground, but just as I reached for it, the tiger sprang up again, ready for one final attack. And this time I was ready. Before it could pounce, I took aim and brought the tiger down. And that's when I realized, in our profession too, with the right strategy, right tools, and a calm mind, every challenging case, like a fierce tiger, can be easily conquered. Thank you so much for your kind attention.
So ladies and gentlemen, we are the blue team, and who won the OPL 2026? Who won the OPL 2026? We, the blue team. So over to Dr. Gaurav Luthra, who is going to give answers to all the other 3 teams in his presentation.
Thanks, Dr. Namrata. So I was with the king of OPL, Dr. Amar himself in Chennai, and he said, Gaurav, Jaipur mein maza karke dikhana. I said, sure, sir. Confident capsules always win. So I passed on to Dr. Mohan Rajan's place, and I saw him astounded sitting in the OT. He says, Gaurav, I'm Superman, but now I'm really foxed, and I've got into big trouble. I operated Aishwarya 10 years back with ICL. Now she developed a detachment, and then, now she's gone on to get a cataract, and my hands are shaking and I'm falling. We all go down types, and, you have to come and save me. So I said, okay, Rajan Eye Care, there are ghosts there, but I'll still do my best. So this ICL had to come out. There was a silicone oil-filled eye. It was a very challenging case because there was also a vitrectomized eye. The PC support was minimal, and as Rajan sir always manages to do some things which Lahane sir said that he can create the things for you. He had created a very dense plaque for me for the live surgery. So Aishwarya's eye, a PC with no support, and dense plaque. So I was, at my wit's end. I said, this is like really an OPL case, Mohan sir. He says, that's the whole idea. So I kept working on it, and with very patient polishing, finally created a plane, and almost like a smile lenticule dissection. I went in from two sides, dissected a plane on the PC plaque, and then finally I was able to get it out, and I was able to save his neck. The 75 times OPL winner finally had to depend upon another team guy to do it. Next stop was in Delhi, and then I see Mahipal sir sitting foxed, bahut pareshan. Gaurav, this time you are my friend. You have to come and help me out. And I've operated upon Shah Rukh's first eye, and he has a posterior polar cataract. And uska femto kiya tha, lekin uska nucleus drop hone wala tha. Second eye, I will stand by you. Don't tell him that you are operating, but you operate. This is a PC, posterior polar cataract, and I'm going to keep talking to him. Okay. So there we start. We went with a femto, and this time he has upgraded from Lensex to Catalyst. So I said, don't worry, sir, we'll manage. And finally, with lot of, proper this thing, care and no rotation of the nucleus. We did a good hydrodelination, left the epinuclear shell intact right till the end, and then disengaged. Then on the intraoperative OCT, we kept watching it that, it's still holding on. And finally, after, kind of releasing it from all sides, I was able to get it out. And Mahipal sir was beginning to look a little relieved that Shah Rukh is not going to kill me, all over the world publicity. So finally, we were here, and then, Ayul Dala, he said, okay, Gaurav, let me take over now. Everything's done. You just stand by the side. And he starts telling Shah Rukh ji, everything's gone very well. So, now you can go home, and there. As soon as he pressurizes the globe, he's done it again. So there's a record of having these PC rents. And, anyway, this happened to me only, but just wanted to show this another case. And now the third team captain, Lahane sir, who's the Superman. And he's, he said, Amitabh Bachchan ko to Himanshu ne kar diya, main Rekha ka karunga cataract surgery. He started doing the cataract surgery, and Rekha ji coughed halfway through the surgery, and there's a situation. The iris is traumatized, and the cataract is there. And then, there's a BOA live surgery, and we have to do something about this. So there's a DMD all over the place. And this is a situation on the OCT. The cataract is all over the place, and there are DMDs, and then this has to be managed. The incision has also got a little damage. So this happens sometimes, and eventually you have to go create a plane with viscoat, and finally make some space for yourself, and then try to assess what is the status of the capsule, and finally, able to get out most of this cataract in a very slow and steady way. And finally, after the cataract is out, it was very challenging to get this out, and especially Lahane sir standing right next to me. I respect him a lot. And we were able to get this cataract out and finally settle the DMD with flotation of the air bubble. And it all happened well because we could see on the OCT that we have the DMD already attached. And with that, I would like to finish. All our judges are really impressed, and Dr. Amar is all over the moon with this presentation, and we won the World Cup also. Thank you.
Thank you, Gaurav, for managing those very challenging cases. And over to our star performer now, Dr. Rajesh Sinha.
Ladies and gentlemen, the posterior polar cataract is something that is considered as the most dreaded scenario. Can I have the video, please? Video.
Audio.
Okay, I'll start once again. So, ladies and gentlemen, as I said, posterior polar cataract is something about which all the cataract surgeons, they feel very scared. And sometimes you do have a pre-existing posterior capsular defect which enlarges during the surgery, and then if it is not handled well, then everything goes for a toss. So I'm going to present to you a case of a posterior polar cataract with a large pre-existing posterior capsular defect. See this large defect as it is visible. It is hardly seen, very rarely seen in any posterior polar cataract. Most of the times you do have a defect in the center and it enlarges during the procedure and then everything falls in the vitreous cavity. But here, this is a unique case wherein you have already a very large posterior capsular defect, and then if you don't handle it properly, then everything will go and fall behind. So it has to be done very meticulously, starting from the capsular axis. The size of the capsular axis should not be more than 5 millimeters, so that later on, if you are putting a multi-piece lens, you can do an optic capture. Then with a slow motion phacoemulsification, with low parameters, you can just keep emulsifying the nucleus without doing any sort of hydroprocedure, because even a little bit of hydroprocedure can completely get everything falling behind, because it's already an open posterior capsule. As you keep on dissecting, you get a thin plate, and when you have a thin plate, you can lift it up with the help of a Sinskey hook and with a phacoemulsification probe. And as you lift it and bring it in the anterior chamber, you can inject something like a viscoat behind the thin layer of nucleus, which is held with the help of a Sinskey hook. So you inject viscoat so that it forms a layer between the nucleus and the capsule. And then you push the nucleus on one side, and then it is being emulsified with the phaco probe. And the whole of emulsification can be done because viscoat does provide a good scaffold over which you can, with high phaco but with a low parameters, you can completely emulsify the nucleus. And once you have emulsified the nucleus, the best thing to remove the cortex is a vitrector with an IA cut mode. Because whenever you just catch hold of the cortex, take the vitrector inside at the cortical area, hold it, and then start the suction and bring it in the center. And if needed, you can use the cutter also by an IA cut mode. So that is how you can completely remove and aspirate the cortical matter completely and keep the visual axis clear. Once the visual axis is completely clear, you also do with a cut IA mode, you do a vitrectomy, and then you enlarge the incision so that you don't want a wound-assisted implantation. Enlarge the incision, place the multi-piece lens in the sulcus, and once it is there, as the capsular axis was 5 millimeter size, it is captured into the capsule. Once it is captured into the capsule, it stays there, rock solid, in the center of the visual axis. Remove the viscoelastic, and this is the end result. On day 1 post-op, the patient has 6/6 partial vision, and the patient was very happy. Thank you very much.
Thank you, Rajesh, for those very practical tips to manage posterior polar cataract. And now I'm going to be showing a video of flip the script, alternatives to allogenic keratoplasty, more so because there is paucity of tissue in our country, donor corneas in our country. So if you have very superficial opacities, you can ablate them like granular corneal dystrophy, lattice dystrophy, or macular dystrophy. So all you need to do is remove the epithelium, ablate the cornea, and after ablating the cornea, one can put a bandage contact lens, and the patient is good to go with good visual results, as can be seen. The second option that can be done, and this has been published in Survey of Ophthalmology by us, the second option that can be done is optical iridectomy, especially in cases of Peters anomaly, children where the graft failure rate is high. So expand the area of visualization, which is also going to be the area of visualization for the child, pre and post-op. And again, this was published by us in Journal of Cataract and Refractive Surgery. The third way to manage is rotational autokeratoplasty, where a picture of the partial corneal opacity is photoshopped through the computer. 2 circles are drawn at the pupil as well as the limbus, And generally, it is annotated as to how the surgery would proceed. So we also plan to do a sphincterotomy in this, and this is what the actual surgery was. The cornea was trephinated because there was cataract, so cataract surgery, implantation of the intraocular lens was done, coupled with whatever the picture was there previously. The same picture was simulated on the actual surgery. So this is computer simulation of the rotational autokeratoplasty. This is the post-operative day 1 and post-operative month 1, and there are no rejection because it is the patient's own tissue, and the patient gets ambulatory and sometimes very good visual acuity. Now when you don't have corneas, again you can use Tennant's patch graft to plug the perforations, as can be seen here, more so for paracentral and peripheral perforations. Tennant's integrates very well into the tissues, also is a autologous source, so there's no chance of rejection, integrates well, fibrosis gets fibrosed. So again, you don't need a donor cornea to do this as well. This was published in Cornea. Biosynthetic cornea, this is something which we are working with the Swedish collaborators, obtained from porcine collagen type 1. This is a case of keratoconus. This is how it looks like, pretty much like a soft contact lens, implanted intrastromally inside, and then a bandage contact lens is applied. Notice this is a sutureless surgery, and again this is a synthetic alternative or stromal construct of the cornea, and this is 8 years down the line follow-up where you can only see a rim, and this was published in Nature Biotechnology with an impact factor of 68.1. Now if the posterior part of the cornea is compromised, EndoArt can be used, and EndoArt is nothing but again a synthetic alternative where epithelium is debrided and the EndoArt is intracamerally injected so that there's a barrier between the aqueous and the cornea so that there is no corneal edema. Again with gratifying results, sometimes lasting results, and sometimes you may have to do endothelial keratoplasty later. And this is the most difficult case, the end-stage disease of the cornea, where again we worked on cornete keratoprosthesis, which is a unique keratoprosthesis with the center of which is made of PMMA. The skirt is Teflon. This is sutured after doing trephonation onto the recipient bed. Again, these cases are such that if you do penetrating keratoplasty with human donor corneas, they will 100% fail. So cornete keratoprosthesis is very useful in these cases, again giving very good vision to the tune of 6.6 to 6.9 in these cases, and this is yet another alternative to human donor cornea, and this again we've published in Current Opinions of Ophthalmology. So if you have partial corneal opacities, ablate it, bypass it, rotate it, use stromal construct, use endothelial construct, or use keratoprosthesis. So ladies and gentlemen, these are the options when you don't have human donor corneas as to how to deal with corneal blindness. Thank you very much for your kind attention.
Thank you very much, Namrata. And Namrata, can you ask your people to get the trophies on top here? Can I have all the speakers on the stage, please? All the speakers come in the back, please. So we'll start with Dr. Kudlu. I want only one name, best entertainer.
Dr. Partha Bishwas.
Partha! Come in the front, Partha. Piyush, quick.
Dr. Partha Biswas.
Partha 2. Partha 3.
Partha.
4.
So one thing is to be noted.
Lahane 1. Partha will change. Mohan. I need Mohan, Partha, and Professor Lahane in the front. Chitra. Anaga, where are you?
Yeah.
Anaga, come in the front.
So one thing you should notice, Amar, the hero of Partha Bishwas movie is also Mohan Rajan.
That's a good one. Correct. Just get the trophies, no? Partha, come in the front.
Trophies, please.
Lahane,
Can we have the trophies,
come.
please?
Anyway, it doesn't matter. Partha, here, I want Lahane Saab here. Where is Lahane Saab? Lahane Saab, come in the front here.
Trophies, please.
Okay. Mohan, come. Okay, ladies and gentlemen, let's hear it for Dr. Partha. How many people are shouting for him? For Lahane first. Oh, good. Okay, for Mohan. Okay, Lahane is winning right now. I'll come to you last. Anaga? Okay, good. So now the choice is Partha. Hey, wait, hold on. It's confusing right now. I've got two more. I've got these two right now in the front of me, okay? Lahane.
Four girls.
Good. Partha. Hey, you're skipping with the back, you guys. Hello. Hey, listen. This is going to be a tough thing. I'm going to give it to both.
Quickly.
For you also?
Yeah, do.
Okay, he wants for... Okay, let's start again, okay? For Mohan Rajan. Okay, Lahane. Partha. 3. Anaga. Okay, it's going to be a joint winners. All four joint winners, yeah, come on. Lahane, okay. Lahane Saab and Partha joint winners. Okay? Fair enough. Okay, let's move. I'll come from this side. Chitra, best video, quick. Kumar Doctor, come in the front. And by the way, ladies and gentlemen, today is birthday of Kumar. So let's hear it for him.
Happy
Kumar.
birthday.
Rohit Om Prakash, come here. Rohit, 2.
Rohit.
3.
Namrata.
Santosh.
Shared between Dr. Namrata Sharma and Dr. Santosh Hanawar.
This is diplomacy.
Shared between Namrata and Santosh 1 hour.
So one second, I have Namrata here. I have Santosh, where are you? Who are the other names you said? Kumar, where are you? 3. Come here. Kumar, samne aaja. So I have got Kumar, Namrata.
Santosh, don't ask them to raise this thing.
Hey, anybody I'm missing here? Rohit, where are you? Okay. Rohit. Okay, let's hear it. For Rohit, how many names? Yay! Hey, come on, yeah! One clap only. Okay, for Santosh. How are you going to compete with that? Okay. Namrata.
Oh!
Good noise. Kumar. Okay, I'm going to give it to Santosh and Namrata joint.
Oh!
Okay? Fair enough. Okay, best team. Kudlu, all the captains come in the front. Give me the name of the captain. Captains come in the front.
The best team, Dr. Lahane.
Lane's team, 1.
Lani sir.
2.
Lahane.
4.
Mohan.
Mohan, come in the front. Lane 5. 6. 7. Lane. I think Mohan, come here.
He's winning, sir.
What team is there? Namrata.
Yeah.
Maipal. Namrata, where are you? Okay, let's hear it for Namrata team. Okay, what about for Lane's team? Hey, next time I tell you all the contestants, bring like this people who can scream for you. Okay. Mohan. Okay. Lane's team. Who's the 4th captain? Huh? Maipal?
Oh!
Hey, you people are from CFS.
He got them, man.
You're not shouting for boss. Huh? Okay. Winner, Lane's team, no doubt about it. Okay. Stand. Hey, get the trophies. Namrata. Trophies mangwa lo na.
So many trophies.
Where is our president?
Can we get all the trophies? Take a trophy, no? Pick up a trophy, please. All the trophies are here.
Please get the trophies. I'd like to thank Namrata and Santosh for this lovely OPL and the entire AIOS.
So many trophies.
Namrata trophies.
रोहित किधर गया? हाँ.
Guys, pick up your own trophies. They're all on the right side.
generic में लिखा हुआ है